What if I told you that the most dangerous place in Victorian Britain wasn't a coal mine, a factory floor, or even a battlefield? It was the doctor's office. Not because of what physicians couldn't do, but because of what they confidently did wrong, day after day, patient after patient, with the unwavering certainty that comes from institutional authority and social prestige. We've been conditioned by period dramas and history books to view the Victorian era as the dawn of modern medicine, a romantic age of scientific awakening, where distinguished gentlemen in frock coats battled disease with stethoscopes and leather medical bags. We imagine progress, crude perhaps, but marching steadily toward enlightenment. The reality was far more sinister. For much of the 19th century, stepping into the care of a respectable, well-trained Victorian physician often meant stepping closer to death. Picture this scene. It's a fog-shrouded London morning in 1850. You climb narrow, worn stairs to a consulting room above an apothecary. The air inside is thick with coal smoke and something else, a metallic, sickly sweet odor that clings to everything. Your doctor rises to greet you, his black frock coat stiff with wear, a thin brown stain barely visible on his cuff. His fingernails are rimmed with dark crescents, and a faint smell of the dissecting room follows him like a shadow. Only an hour ago, this same man was elbow deep in a corpse, tracing the pathways of disease he didn't yet understand. He wiped his hands on a rough towel, dipped them briefly in murky water, and now, without gloves, without soap, without the slightest conception of invisible threats, he reaches out to examine you. Those same hands will shortly attend a birth, probe an infected wound, prescribe mercury-laden medicines that will slowly poison your organs. And no one will question this, because here lies the first and most lethal myth of Victorian medicine, the belief that visible cleanliness equaled actual safety, that a gentleman's hands were clean by social definition, and that confidence could substitute for competence. Chapter 1. The Theater of Blood. To understand the sheer terror of Victorian surgery, you must first understand that the operating room was not a sterile sanctuary, but a public spectacle indistinguishable from a slaughterhouse. The Victorian operating theater was exactly that, a theater, complete with tiered seating packed with medical students, curious spectators, and social elites who came to watch the show. Imagine entering one of London's prestigious teaching hospitals in 1840. The air assaults you immediately, thick with the metallic stench of old blood, stale sweat, and the sawdust scattered across wooden floors to absorb bodily fluids. There are no sterile white walls, no rhythmic beeping of monitors, no quiet hum of air filtration. Instead, the room buzzes with conversation, laughter, and the scraping of boots on blood-soaked boards. Rising in tiers around the central wooden table are rows of benches packed with spectators smoking pipes and jostling for better views. Their street clothes carry the grime of London's sooty air directly into the surgical space. In the center stands the surgeon, the archetype of Victorian medical authority. He wears no mask, no rubber gloves. Instead, he sports his favorite frock coat, a garment stiff with the dried blood and pus of countless previous operations. This filth isn't negligence. It's a badge of honor proving his experience and success. The patient strapped to the wooden board faces an unimaginable ordeal. There is no anesthesia, ether and chloroform are still experimental, or viewed with suspicion by surgeons who believe pain stimulates the heart and prevents shock. The patient is fully conscious, eyes wide with primal terror, given only a leather strap to bite and perhaps a swig of brandy that does nothing to dull the agony ahead. Speed becomes the only mercy. Robert Liston, known as the fastest knife in the West End, could amputate a leg in under 30 seconds. But this frantic pace came at a horrific price. In the screaming chaos of rapid surgery, accuracy was often sacrificed. There are documented cases of surgeons moving so quickly they accidentally severed assistants' fingers or slashed spectators' clothing. In one infamous operation, Liston's speed resulted in the deaths of the patient, his assistant, and a spectator. The only surgery in history with a 300% mortality rate. But the true horror wasn't the knife itself. It was what happened afterward. The surgeon would wipe his bloody scalpel on his coat or boot, slide it back into a velvet-lined case, and thread a needle often kept stuck in his lapel for convenience. He would stitch the wound with the same hands that had just been inside multiple bodies, never washing between patients. Why would he? A gentleman's hands were clean by definition. The audience would applaud this performance while the patient, pale and shivering, was carted off to a ward where stagnant air and reused sheets awaited. The surgery was declared successful, but the patient would likely be dead within a week from hospital fever, an act of God, not medical failure, in the minds of those who created it. This paradox defined the era. The more complex the surgery, the more likely the death. As surgeons grew bolder, cutting deeper into the human body, they unknowingly planted microscopic seeds of destruction in their patients' tissues. They were explorers in a new world, but they explored with contaminated tools, trampling the very lives they sought to save. Yet if the operating theater was a place of loud, screaming horror, there was another room in Victorian hospitals where death moved more quietly, and perhaps more cruelly. Chapter 2: The Mother's Curse and the Invisible Assassin. Walk down the corridor from the blood-soaked operating theater to the maternity ward, and the atmosphere changes dramatically. Here, the sounds are different. The cries of newborns punctuated by low groans of women in labor. This should be a sanctuary where the Victorian ideal of family is physically realized. Instead, for decades, it functioned as a death trap that baffled the greatest medical minds of the age. This was the domain of puerperal fever, or childbed fever, a mysterious plague that struck healthy women days after successful deliveries. It began with chills, progressed to fever and agonizing abdominal pain, then delirium, and finally death. In some hospitals, mortality rates for new mothers reached 30%. A woman entering a hospital to give birth had a 1 in 3 chance of leaving in a coffin. The tragic irony was that the doctors themselves were the vectors of death. In the great teaching hospitals of Vienna, London, and Paris, the day typically began in the morgue. Medical students and professors would spend mornings dissecting corpses, their hands submerged in rotting flesh, to learn anatomy. This was the era of the anatomical renaissance, where knowledge was prized above all else. After finishing their dissections, they would wipe their hands on communal rags and head directly to the maternity ward to perform vaginal examinations on laboring women. They carried microscopic particles of death, cadaverous material teeming with Streptococcus bacteria, directly from the deceased to the living. They literally introduced death into their patients' bodies. Enter the tragic figure of Ignaz Semmelweis, a Hungarian physician working in Vienna in the 1840s. Semmelweis was haunted by the screams of dying mothers and tormented by a chilling statistical anomaly. His hospital operated 2 maternity clinics. One was staffed by doctors and medical students, the other by midwives. The death rate in the doctor's clinic was 3 times higher than in the midwives' clinic. Women knew this terrifying difference. Historical accounts describe pregnant women begging on their knees not to be admitted to the doctor's ward, preferring to give birth in the streets rather than enter that house of death. Semmelweis stripped away variables systematically: ventilation, diet, religious practices, but found no explanation until a colleague died after cutting his finger during an autopsy. The colleague's symptoms were identical to those of women dying from childbed fever. Semmelweis made the connection that was obvious to him, but heretical to his profession. Cadaverous particles were being transmitted from the dead to the living. He instituted a simple rule: everyone must wash their hands in chlorinated lime solution before examining patients. The harsh, bleaching chemical stripped the skin, but it worked. Mortality rates plummeted from 18% to nearly 1% virtually overnight. You would expect Semmelweis to be hailed as a hero. Instead, he was mocked, ostracized, and eventually fired. His theory attacked the very identity of Victorian gentlemen doctors. To accept his findings meant admitting that they, healers, men of science and high social standing, were actually vectors of death. The medical establishment's collective ego could not withstand this truth. Leading obstetricians argued that gentlemen's hands were socially clean and therefore could not cause disease. They preferred ancient theories of miasma, that disease was caused by bad air, not physical contact. They blamed the weather, planetary alignments, or the moral failings of the women themselves rather than confront their role in the carnage. Semmelweis was driven to desperation by the medical community's rejection. He spent his final years writing increasingly angry letters to prominent obstetricians, calling them irresponsible murderers. He was eventually lured into an asylum, beaten by guards, and died of blood infection, the very condition he had spent his life fighting. Meanwhile, across Europe, doctors stopped washing their hands. Death rates soared again. Thousands more women died, sacrificed on the altar of professional vanity, while the invisible assassin continued stalking maternity wards, protected by the arrogance of the men sworn to defeat it. But if hospitals were dangerous, surely one was safe at home, taking medicines prescribed by trusted family physicians? The medicine cabinet, as we'll discover, was perhaps the most treacherous place of all. Chapter 3. The Poison Cabinet and Heroic Medicine. Leave the hospital now and enter the Victorian home, a wealthy drawing room heavy with velvet curtains and coal-fire heat. A child is coughing. The mother sends a servant to fetch a remedy from the apothecary. The bottle that returns is beautiful, cobalt blue or amber glass, with an intricate label, promising soothing syrup or restorative tonic. The Victorian era was the golden age of patent medicine, but it was an unregulated wilderness of chemistry. With no FDA, no clinical trials, and no ingredient labels, pharmacology became a game of Russian roulette played with chemistry sets. The trusted family doctor, lacking effective antibiotics or antivirals, relied on a pharmacopoeia that reads today like a catalog of banned hazardous substances. The big three of Victorian medicine were mercury, arsenic, and opium, substances we now recognize as deadly poisons, but which were then prescribed with absolute confidence for virtually every ailment. Consider the standard treatment for syphilis, a rampant disease of the era. Doctors prescribed mercury in various forms: vapor baths, pills, ointments. The side effects were horrific. Patients would salivate excessively, producing pints of saliva daily. Their gums would rot and teeth fall out. They would slowly descend into madness. The saying "a night with Venus, a lifetime with Mercury" grimly acknowledged that the cure was a slow, torturous form of poisoning. Yet doctors persisted, convinced that violent physical reactions meant the medicine was working to drive out corrupt humors. Arsenic, today known as rat poison, was prescribed as a tonic. Fowler's solution, a mixture of potassium arsenite, was recommended for everything from malaria to asthma to skin conditions. It gave patients a blooming complexion, actually the result of capillary damage, before systematically shutting down their organs. People literally paid doctors to administer cumulative doses of heavy metal poison. The most insidious killer was opium, the aspirin of the 19th century. Available without prescription at grocers, pubs, and pharmacies, it was marketed most aggressively for children. Mrs. Winslow's soothing syrup was a household staple advertised to soothe teething babies. It contained morphine and alcohol. It certainly soothed them by putting them into comas. Countless infants died of respiratory failure, their blue lips and pale skin attributed to convulsions or weak constitution when they had actually been overdosed by their own parents on medical advice. This chemical warfare against the human body was driven by the philosophy of heroic medicine, the belief that severe illness required severe treatment. The body had to be shocked into health through purging, blistering, bleeding, and sweating. If medicine didn't make you violently ill, it wasn't strong enough. Bloodletting stood as the cornerstone of this approach. Using lancets to deliberately drain blood from sick patients, doctors removed staggering quantities, 20 to 30 ounces per session, sometimes repeatedly over days. Consider what this meant for someone already weakened by disease. Their body was fighting infection, while doctors systematically drained away the very fluid, carrying oxygen and nutrients to tissues. The combination of bloodletting and purging created perfect storms of physiological disaster. A pneumonia patient needed rest, fluids, and nutrition to fight infection. Instead, they were bled until weak, purged until dehydrated with mercury-based calomel, and often denied food because doctors believed feeding a fever was dangerous. Their bodies, already under assault from disease, were systematically stripped of every resource needed for recovery. Lord Byron, the famous poet, died at 36 from a fever that should have been survivable with rest and fluids. Instead, his doctors bled him repeatedly, removing more than 2.5 pints of blood over several days. Weakened beyond recovery, Byron died while physicians congratulated themselves on doing everything possible to save him. The psychological mechanism at work was both fascinating and terrifying. When patients recovered after bloodletting and purging, the treatment received credit. When patients died, the disease was blamed or treatment was deemed too late or too timid. This confirmation bias created a closed loop, making the theory unfalsifiable. Every outcome could be interpreted as supporting the treatment's validity. But where did these confident doctors learn the anatomy that allowed them to wield such authority? Where did they practice before poisoning the living? The answer lies in the criminal underworld that supplied raw material for medical education. Chapter 4. The Shadow Trade and Institutional Blindness. Every Victorian doctor needed an education, and the only way to learn human anatomy was dissection. But legal bodies, those of executed murderers, couldn't meet the exploding demand from medical schools. This supply crisis birthed one of medicine's darkest chapters, the era of the resurrection men. These weren't doctors, but criminal gangs working graveyards by night. They would dig up the freshly buried, crack open coffins, and hoist bodies out with ropes. They stripped shrouds, stealing clothes was felony, stealing bodies only misdemeanor, and stuffed corpses into sacks for delivery to medical schools' back doors. Highly respected surgeons, men knighted by the Queen, paid cash with no questions asked for fresh corpses delivered at 2 a.m. They knew where bodies came from, knew grieving families were waking to disturbed graves, but justified it in science's name. The anatomy room became a place of systematic desensitization, where medical students played catch with organs, smuggled bones in their pockets, and ate lunches beside partially dissected bodies. This culture of detachment was necessary to survive the smell and horror, but it bred dangerous lack of empathy. Patients became material, human beings became specimens. In Edinburgh, Burke and Hare realized waiting for natural death was inefficient. They began murdering lodgers and selling fresh bodies to Dr. Robert Knox, a famous anatomist who never questioned why corpses were so fresh or unmarked by illness. When these crimes were discovered, Burke was hanged, but Knox, the client, the doctor, was never prosecuted. This scandal exposed the rot at medicine's heart. The foundation of medical knowledge was built on desecrating the poor. The wealthy could afford iron coffin cages or private mausoleums, but the poor ended up on dissecting tables. Meanwhile, in hospital wards, this anatomical training translated into systematic contamination. Victorian hospitals functioned as extraordinarily efficient machines for concentrating and spreading disease. Typical wards were long rooms with beds placed close together, separated only by curtains. Ventilation was poor, heating inconsistent. Patients with broken legs lay beside those dying of tuberculosis, with surgical patients recovering from amputations on the other side. The concept of isolating infectious patients didn't exist systematically. Diseases mingled freely in ward atmospheres. Patients admitted for one condition often contracted several others during hospital stays. The term hospitalism described the constellation of infections, erysipelas, gangrene, pyemia, septicemia, that seemed to spontaneously generate in hospital environments. Nursing staff moved from patient to patient without understanding disease transmission. The same water basin washed multiple patients. Bedpans were rinsed and reused without proper cleaning. Soiled bandages were sometimes washed and reused rather than burned. Surgical wards presented even grimmer pictures. After operations, patients returned to open wards where wounds became exposed to teeming microbial life. Dressings were changed infrequently, and when changed, old ones were dropped on floors or into buckets, then carried through wards spreading contamination. Wounds often became infected within days, flesh turning red, purple then black as gangrene set in. The characteristic smell of hospital gangrene, sweet, sickening, unmistakable, permeated surgical wards. Surgeons made rounds with entourages of students, examining wounds by probing them with unwashed fingers, sometimes using the same instruments on multiple patients without cleaning between uses. They practiced pus bonum et laudabile, good and praiseworthy pus, believing suppuration was necessary for healing rather than recognizing it as infection. The mortality statistics were almost incomprehensible. Major amputations carried 50% mortality rates, not from surgery itself but from subsequent infections. Compound fractures were often death sentences. Abdominal surgery was rarely attempted because infection rates approached 100%. What made hospital mortality rates even more tragic was evidence that they were demonstrably worse than outcomes outside hospitals. Home births attended by midwives resulted in far lower puerperal fever rates. Surgical procedures in private homes had better outcomes. The statistics were clear. Hospitals were dangerous places, yet this evidence was explained away or ignored because hospitals were modern scientific institutions that surely must be superior to home care. But how long could such willful blindness persist when the evidence became overwhelming? Chapter 5. The Painful Dawn of Understanding. By the 1860s, the carnage had become undeniable. But change came not from London's charismatic surgeons, but from a quiet Quaker chemist in France and a somber Scottish surgeon. Louis Pasteur proved that decay was caused by living organisms, germs. Joseph Lister read this work and made the crucial leap: if microorganisms cause putrefaction in dead tissue, might they not cause suppuration and gangrene in surgical wounds? Lister began experimenting with carbolic acid as an antiseptic. He soaked surgical instruments in it, sprayed it in operating rooms, and applied it to wounds. The sensory experience of surgery changed from rotting blood smells to sharp chemical stings of antisepsis. His results mirrored Semmelweis's. Surgical infection rates dropped dramatically. Patients survived amputations that had been death sentences. Yet the British medical establishment's response was only marginally better than Vienna's had been to Semmelweis. Many surgeons rejected Lister's methods as unnecessarily complicated. Carbolic spray was unpleasant, procedures time-consuming. More fundamentally, accepting Lister's theory meant accepting that current practices were killing patients, that operating theaters were death traps, that their own hands and instruments were disease vectors. This psychological difficulty for men who had spent careers believing they were healers made it easier to dismiss Lister as a faddist than confront the implications of his work. One famous surgeon was known to joke, "Shut the door, you're letting Mr. Lister's microbes in." Followed by raucous laughter from students. The resistance to germ theory reveals profound truths about human nature and institutional inertia. When evidence conflicts with deeply held beliefs, professional identity, and social status, humans are remarkably adept at dismissing or reinterpreting that evidence. Victorian doctors weren't uniquely stubborn. They displayed universal human tendencies to protect worldviews and self-concepts against threatening information. Moreover, Victorian medicine's structure made germ theory acceptance particularly difficult. Medical authority rested on theoretical knowledge, understanding humors and constitutional types, making learned pronouncements about disease causation. Germ theory reduced this grand edifice to something embarrassingly simple. Tiny organisms cause disease, and the solution was basic hygiene. This threatened to demote doctors from learned gentlemen to mere technicians of cleanliness. The delay in accepting antisepsis and asepsis cost countless lives. For 20 years after Semmelweis's discovery, women continued dying of childbed fever across European hospitals. For decades after Lister's publications, surgeons operated without antiseptic precautions, while patients died of preventable infections. Medical establishment pride, institutional conservatism, and inability to admit error translated directly into mortality statistics. Gradually, however, the tide turned. Young doctors trained in bacteriology entered the profession with different ideas about disease causation. Generational change proved crucial. Science often advances one funeral at a time, and this was certainly true for germ theory acceptance. Hospitals began implementing systematic hygiene protocols. Wards were redesigned with better ventilation, more space between beds, separate rooms for infectious cases. The transformation from antiseptic to aseptic technique represented another conceptual leap. Antisepsis used chemicals to kill germs on instruments and in wounds. Asepsis created environments where germs couldn't enter, sterilizing instruments through heat, wearing sterilized gloves and gowns, maintaining sterile surgical fields. This required even more elaborate procedures and greater departure from traditional practice, yet those who adopted aseptic technique saw mortality rates drop further still. Chapter 6. The Price of Progress and Modern Parallels. As we look back on Victorian medicine from our 21st century vantage point, what lessons emerge from this dark chapter? The story of how Victorian doctors killed more patients than they saved isn't merely historical curiosity. It's a cautionary tale with profound implications for how we think about medicine, science, and institutional authority today. The most obvious lesson concerns the danger of treating theoretical frameworks as unquestionable truth. Victorian doctors weren't evil or stupid. They operated within paradigms that seemed sensible given their assumptions. Humoral theory had ancient pedigrees and appeared to explain disease patterns. Miasma theory aligned with sensory experience. Foul-smelling places did breed disease. The problem was that these plausible theories were wrong, and medicine's institutional structures made recognizing and correcting errors extremely difficult. We must ask ourselves, what theories do we hold today with similar confidence that future generations will recognize as dangerously misguided? The resistance to Semmelweis and Lister reveals how social factors can override empirical evidence. Doctors rejecting hand-washing weren't disputing statistics. The numbers were clear. Instead, they rejected the implications because accepting them would threaten their social status, self-concept as healers, and professional dignity. This teaches us that in evaluating medical claims or scientific theories, we must recognize how social and psychological factors influence reasoning. Evidence alone isn't always sufficient to change minds when powerful interests and identities are at stake. The Victorian experience demonstrates the double-edged nature of professionalization and institutionalization. Medical schools, hospitals, and professional organizations were meant to improve care through standardized training and practice. But these same structures made challenging orthodoxy harder, created hierarchies that suppressed dissent, and ensured errors were propagated systematically. The Victorian experience also demonstrates humility's critical importance in medicine. Doctors who did the most harm were often those most confident in their knowledge and methods. Aggressive interventions, extensive bloodletting, harsh purging, repeated examinations of laboring women stemmed from beliefs that doctors should always do something, that active intervention was always better than watchful waiting. Sometimes the best medicine is the least medicine, a lesson each generation seems to need to relearn. We must also consider the class dimensions of Victorian medical harm. The wealthy, who could afford the best doctors and hospital access, often received the most aggressive and harmful treatments. The poor, who couldn't afford medical care, sometimes fared better through benign neglect. This inverts our usual assumptions about medical access and outcomes. The delay in accepting germ theory, decades between Semmelweis's discovery and widespread antisepsis adoption, represents quantifiable moral failure. We can calculate roughly how many people died unnecessarily during those years of resistance. Hundreds of thousands, perhaps millions. These deaths weren't inevitable consequences of limited technology or knowledge. They resulted from institutional inertia, professional pride, and medical establishment inability to admit error. Yet we must be careful not to feel superior to Victorian doctors. We live in an age of evidence-based medicine, randomized controlled trials, and systematic reviews. But we're not immune to the same cognitive biases and institutional pressures that led Victorian medicine astray. Modern medicine has its own orthodoxies, practices that continue despite questionable evidence, resistance to challenges from outsiders. The opioid crisis, overuse of certain surgical procedures, medicalization of normal human variation, these suggest we're still capable of systematic medical harm, just in different forms. Victorian medical stories raise questions about how we evaluate progress. Medical technology has advanced enormously, but has medical wisdom kept pace? We have powerful tools, advanced imaging, sophisticated pharmaceuticals, complex surgical techniques. But do we always use them wisely? Victorian doctors had primitive tools, but used them with great confidence. We have advanced tools, and must ensure we don't wield them with similar overconfidence. Every medical intervention carries risks, and the question is always whether benefits outweigh harms. The Victorians got this calculation catastrophically wrong. The role of profit and prestige in medicine deserves scrutiny. Victorian doctors had financial and social incentives to perform interventions. Bloodletting and purging required doctor services, while rest and fluids didn't. Modern medicine faces similar perverse incentives where procedures and prescriptions are more lucrative than preventive care or watchful waiting. Fee-for-service models encourage intervention over restraint, just as they did in Victorian times. Finally, the Victorian medical experience teaches us about the nature of medical progress. It's not smooth, linear advancement, but halting, uneven process with many wrong turns and backsliding. Progress often comes from outsiders challenging orthodoxy, careful observation overturning theory, accumulation of negative evidence, finally overwhelming entrenched beliefs. This means we should value dissent in medicine, protect those who challenge established practices, and create institutional structures that encourage, rather than punish, questioning of authority. The transformation of medicine from a profession that killed to one that heals represents genuine human civilization achievement, but it took far longer than necessary, cost far more lives than it should have, and teaches us that good intentions and professional authority are no guarantee against systematic harm. The ghosts of Victorian patients, women who died of childbed fever, surgical patients who succumbed to gangrene, countless souls bled and purged to death by well-meaning physicians, remind us that medicine is not just science, but moral enterprise. The first principle must always be do no harm. And living up to that principle requires constant vigilance, humility, and willingness to admit when we're wrong. Victorian doctors failed this test catastrophically. Their story stands as permanent warning about the dangers of certainty, the importance of evidence over theory, and the moral obligation to question authority when lives are at stake. We honor their victims not by forgetting this dark chapter, but by learning from it, remaining forever skeptical of our own orthodoxies, and remembering that the confidence with which we practice medicine is no guarantee of its wisdom. So when you next encounter absolute certainty in medical pronouncements, remember the Victorian physician with his blood-stiffened coat and unwashed hands. Ask yourself, what invisible threats might we be carrying today? What practices that seem obviously beneficial might future generations view with horror? The price of medical progress has always been paid in human lives. Our obligation is to ensure we're not still collecting that terrible toll through our own unexamined certainties. What aspects of modern medicine do you think future generations might judge as harshly as we now judge Victorian bloodletting and unwashed hands? Share your thoughts, and remember to question authority, especially when lives hang in the balance.